do it in conjunction with the U of U, and they found some of the people were doing brain scans, and they found that new neural pathways were being developed in the brain.
Hi,
everybody. For that constant stress.
Hi, we're going to get started.
We'll get going.
Oh, okay. And present Luke Aust,
Yes.
Pharmacy Student.
Yes, thank you for being here. For those of you who don't know me, I'm Luke Aust, a pharmacy student at the University of Wyoming, completing my final rotation. So I'm actually my last week here at Memorial Hospital. And Renee brought up the idea of doing a presentation, and specifically on the medication Soliris, or Soliris.
How are we supposed to say it? Because I've been just blathering off.
So yeah, I'm glad you asked, because as you notice, I titled my presentation, "The Suns Have Eyes." It's kind of a weird name. And to break it down, if you do a Google search of how it might sound phonetically, a lot of people pronounce it Soliris. But if you search that, you'll find a 2002 movie, a romance sci-fi movie that has George Clooney in it. So for those of you who care about spelling, make sure you want to get a lot of these complicated named drugs spelled right. You break it down: Sol, S-O-L, and iris. Sol means sun, iris, you know, the colored part of your eye that constricts your pupil. So Sol, iris, suns have eyes. Cheesy pun off of a horror movie. Anyway, as we go throughout today, I want to introduce that medication to you guys. I want to go over some of the very complicated disease states which it's indicated for, discuss kind of how it works, where it fits within that cascade, how you give it, how it's dosed, as well as some important safety issues that are relevant to Soliris. And then lastly, I'm in the pharmacy department, obviously, and so I want to examine how the pharmacist role fits in specifically with that. So you guys, whether you're pharmacy or not pharmacy, you have a little bit better idea of how that works. So just to introduce you, it's again Soliris, or the generic name is eculizumab. I looked that one up on pronunciation. It was approved in 2007. And it's a part of a class of medications called monoclonal antibodies. You might see on TV a lot of commercials for, this is a growing, kind of newer type of therapy, and basically it's supposed to, or the drugs are kind of enhance things that go on in your immune system. So they're very targeted therapies, and you can get some pretty cool things, pretty cool effects with them. Specifically, this one is indicated for two disease states, atypical hemolytic uremic syndrome and paroxysmal nocturnal hemoglobinuria. And I'll go through kind of what each of those are now. So first, atypical hemolytic uremic syndrome it kind of happens based off an uncontrolled activation of your complement system, which is part of your innate immune system. And again, I'll kind of break that down. It's called atypical because it only represents about 10% of the cases of hemolytic uremic syndrome. The other 90% happen typically from bacterial infections like E. coli or other staph type of bacteria which produce Shiga-like toxin. But this one is more, again, it's atypical. It can be classified as familial or sporadic. Basically what that means is this one is more caused because of genetic defects, which, and again, I have a picture later that details it better, but it enhances your immune system to the point where you get uncontrolled activation and you get breakdown of your red blood cells. You can get anemia, hemolytic anemia, things like that, and it actually has a pretty poor prognosis. So up to 25% of patients with this without treatment can have mortality. 50% can develop renal failure if it's not treated early. So it's pretty serious. The other one is paroxysmal nocturnal hemoglobinuria, which is a mouthful. But basically this is kind of the same thing. It's characterized by destruction of your red blood cells, and that releases hemoglobin into your system. And basically what that can do is it binds up haptoglobin, and then once it's finished on binding all the haptoglobin, it binds up nitric oxide levels in your periphery. And there's a lot of things that can happen with that. Basically, nitric oxide is good for your vessels, keeps them dilated, so you can get a lot of vasoconstriction, peripheral or pulmonary hypertension, lots of complications. But there's three key aspects with that: the hemolytic anemia, which is breakdown of the red blood cells, pancytopenia, so really across the board. Your red blood cells, white blood cells, platelets can be destroyed. You get low, and then eventually, what leads to a lot of the causes of death is this thrombosis. They're not exactly sure what leads to it, but you can have thrombotic events, develop clots, and ultimately lead to mortality. So again, both of these disease states are very serious. So, where
I have a question.
Yes, please
Can I ask you a
interject.
question?
Absolutely.
So
Yeah.
both of those, I mean, the last one you said was genetic, and was the prior
Yeah.
one genetic too?
It is, yeah.
Atypical?
So
Okay.
I read an article about it, and it says it can be classified as familial or sporadic, which I didn't really understand the differentiation, because familial is obviously like a direct genetic link. Sporadic would mean that your family members don't necessarily have it, but still it's a genetic defect. So I'm not sure why they differentiated that. Basically, what you need to know is that it's pretty rare in terms of hemolytic uremic syndrome, but it is because of a genetic defect and not caused by the bacteria. And again, I'll show a picture which helps it make it a little more tangible, because
And
it's
so both of those, I
Yeah.
would assume at some level they do a genetic test for?
um,
check and see if you
yeah,
have the
yeah,
gene
they do,
for
and
it?
I don't exactly know how
Okay.
they test for that, but yeah. Good question. Yeah, please interject with questions at any time, because it is pretty complicated. So again, like I said, Soliris is a monoclonal antibody. So it binds to, basically in that cascade of the breakdown, it binds to what's called complement protein C5. So again, I talked about the complement system. It's part of your immune system. And it basically prevents it from cleaving into these two different proteins. Specifically, C5b leads to the production of something called membrane attack complex. And again, that's what kind of breaks down your red blood cells. And typically, you think your immune system is really good. Obviously, you want it to attack damaged cells, but essentially what's happening is it's like an over-amplification of your immune system, and so that's what's breaking down these cells. So Soliris acts to kind of stop the over-amplification of that breakdown. So again, you lead to stabilization of hemoglobin. Prior to this, patients would have to receive a lot of red blood cell transfusions, so it kind of decreases the need for that, and ultimately improves cases long term. So here's a diagram from the Soliris website, so you can see kind of the so there's the different pathways. There's your complement system, and like I was saying, you get this with these disease states, you get this over amplification and cleaving of that C5 protein, which leads to this membrane attack complex where you get the cell lysis, a lot of the inflammation and adverse effects. And so where Soliris fits in is it kind of binds to that C5, stabilizes it, and prevents as much of the breakdown. And ultimately, that's how you treat the diseases. Yeah.
So that's C5b9, platelet activation. So that increases the amount of platelets in your system? Is that what that means?
Yep. And like I was saying, like the thrombotic or development of like clots in your system. So that can also, if it's not treated, that's one of the complications as well.
And so this medication will help to lower or regulate that platelet activation.
Right, yeah. So it essentially helps the, overregulation of,
Production?
yeah, overproduction, that's a good way to put it, of of clots. And so it's not really like a anticoagulant necessarily, it's more just bringing you back to like what it normally should be, baseline.
Thank you.
So, yeah, good question. So yeah, any other questions about this chart before I move on?
So ordinarily, real quick,
Yeah.
ordinarily, in those of us that don't have this condition, would our C5 be breaking down into C5A and C5B just at a slower rate?
Exactly.
than
Yep.
other
I mean,
people?
it's
Okay.
a really good thing, because without it, you need this normal process to happen. But essentially, what's happened in these patients is this genetic modification has really just amped up this process to where you get the over breakdown of red blood cells, which leads to all the complications that I described. So, yeah, good question. This should happen, just not quite as fast. So, So Soliris is an injectable given as a IV infusion. With a lot of infusions, of course, it's good to allow them to warm up to room temperature, just as far as comfort for the patient. You want to make sure it's diluted to a concentration of 5 milligrams per mil. You can infuse it a little bit faster in adults, but ultimately it's just kind of a balancing act for making sure that there's no infusion reaction. So with any infusion, you just want to make sure there's appropriate monitoring, make sure the patient handles it well, things like that. And so as far as the dosing goes, patient specific. So the dosing is a little bit lower in the PNH as far as the hemolytic uremic syndrome. But basically the way it works is you dose weekly for 4 weeks, and then on week 5 you increase that dose, and then you dose every 2 weeks thereafter. And
The rest of their lives.
pretty much indefinitely, yeah. So if for whatever reason patients aren't tolerating it, you can discontinue, but understanding that it is a genetic disease, lifelong, and so yeah, it's a burden, but it works as the situation.
Yeah,
So.
and
Exactly.
I think the conundrum we have with this drug and drugs like it is that because you're making new blood cells all the time, you're having to infuse this all the time because you're having to slow that process all the time, and we're just not ahead. We're not upstream of that process any further than that particular treatment.
Yeah.
Exactly.
So it's a constant flow of medication, even though the red blood cells, aren't they reproduced every 90 days or something like that?
Yeah,
Yeah.
it isn't. Yeah.
I think that's the idea is we have this constant reproduction of blood cells, you're correct, and so like on day 1, day 2, you're getting new blood cells, but they're all dying off on the backside. And I think this, where they hit it where every 2 weeks they figured out that they've been able to keep people stable without having to worry about the side effects of too much of this medication versus not having enough of the medication. That's kind of where it balanced out.
Yeah, exactly. So, and I didn't mention it earlier, but the hemolytic uremic syndrome, is more common in children under the age of 5. That's when it's most commonly diagnosed. But the PNH is typically more seen in younger adults. And so, as far as treatment goes, it's not indicated in pediatrics, but the dosing for the AHUS is weight-based up to 40 kilograms, where after that they would just be at the normal dosing regimen. And so that's about 88 pounds. Geriatrics, same as adult dosing. And one thing in particular is, as far as patients with renal or hepatic impairment, they just haven't really studied, had enough time to study, maybe dose modifications for those types of patients. So that'll be something to watch out for down the line. But so far yet, no recommendations. In terms of medication safety, so these monoclonal antibodies in general are, again, good because they can provide very targeted therapy. A drawback of some of them is that they can have some pretty prevalent side effects. First I just listed some common ones that you'll see in a lot of medications. Nausea, vomiting, diarrhea can be pretty common, unfortunately, as well as some more serious side effects. Peripheral edema, hypokalemia, those are just a couple. You can also get hypertension can be a side effect. The biggest one, though, and this is one of the biggest warnings, is they notice that patients can have an increased risk of meningococcal infection. And so there's actually a REMS program, which is Risk Evaluation and Mitigation Program, which basically means you have to go through a process to become certified to give this medication, healthcare providers. And patients must receive that vaccine 2 weeks before they start therapy, unless therapy is dire, but the optimal is getting that vaccine 2 weeks before they begin.
So is that
Soliris.
just a one-time thing, or do you have to do it every once in a while since you're doing this lifetime?
So the vaccine, you just get the once, but then you would resume, I guess, normal vaccination protocol. Which that's a good question. I'll have to look up, when you would need revaccinated for that. But yeah, if you haven't had it yet, you need to get it 2 weeks before new therapy. So, kind of putting this all together, role of the pharmacist in all this situation. Of course, not all of you are pharmacy, but it's important that we counsel patients on medication side effects, which, what were some of those again? about some of the more, yeah. Okay, I heard it back there, I'm way back there. Okay, ensure patients receive appropriate vaccination in time, which I just talked about, but when was that again?
At least 2 weeks before,
All right, what would be the exception for that?
unless it was dire.
Yep, you need therapy right away, good stuff. Make sure the dosing is appropriate based on the specific indication, and which one of those is only indicated for adults?
PMS. I'm thinking.
PMS. It was the one on the left.
Paroxysmal Nocturnal Hemoglobinuria. Absolutely. Good job. And then lastly, or second last, handle the medication carefully to avoid waste. Why do you think that might be?
Because it costs a freaking
Expensive.
ton.
This
It's more
medication-
than its weight in gold.
Yes.
I'm telling you.
This medication is super
About
expensive.
$25,000 a dose.
Yeah.
That's the cost.
The cost.
Oh my goodness.
Yeah, per dose.
And yet you have to take this
Every 2
constantly?
weeks.
Yeah.
So don't drop it and
No,
keep
never
your
drop
sum.
it.
I shouldn't put that one in bold because yes, this medication is very, very expensive. Yeah, obviously it's great. It's a great therapy, but very expensive. And lastly, with any healthcare provider, we want to be watching for clinical updates. Relatively, it's still a new medication, so we want to watch for new studies as we learn more about how effective this medication is and any adjustments to that. So with that, there's my references, so you know that
So you look
what I
stuff
said
up.
is founded upon fact.
Uh-huh.
And thank you for listening. I would love to take your questions now.
So is there a website that you can go to and sign up for to get the updates automatically on the computer as
For-
more about the-
Oh, for clinical updates? There'd be things, I guess not specifically for Soliris. I know there's, you can sign up for like listservs where you get just clinical updates in general. And you just would have to watch out for, Soliris. But I'm not aware of one specifically for
For
Soliris.
that.
But I know,
You can sign up on the FDA website, but then your
Yeah.
inbox is going to be full.
Yeah,
Yeah.
so it'll be very full.
you get a lot of,
Get
because
you
there's a lot of
on Tylenol.
medications.
Yeah.
Yeah. So, good question.
Is there a mortality rate for the Uremic syndrome, or?
Yeah, so without treatment, it can be 25%.
Was that the other one, or was that both of them?
So that was the Uremic syndrome, the PNH. Yeah,
15%.
I saw it
I'll-
on the first one.
yeah, the first one. I'll have to double check on that one. I don't want to. 50's coming. I think 50%'s coming to my mind, but I'll look it up and let you know for sure. I'll write that down.
So one of the thoughts I had that was, well, I mean, I'm sure that they controlled for this, otherwise they wouldn't have bothered to open an entire REMS program on it, but the meningococcal, I mean, obviously that's your patient population that would get meningitis, right?
Right. Yeah.
But I would assume that they saw a high enough risk rate that is what probably spurred the REMS program.
Yeah. And I couldn't find a specific, I guess, rate of incidence of that. It was just
Yeah.
enough that, like you say,
Made them nervous or something.
yeah, and they, so they set up a REMS program.
Weird question, but do we happen to know if this drug has orphan drug status? I don't know, I hadn't looked into it.
That's a good question. In my research, I didn't see anything about that, but I'll
And I forget,
look
what's
into
the
that.
cutoff? Is the cutoff for an orphan drug less than
It's
100,000?
200.
You might be right, 200,000?
200,000?
That's what I thought.
I think you might be right. So less than 200,000 cases. And
Like, need to have the condition
Yeah.
in order to have the.
So, in the U.S. or
yeah,
okay,
in the
because
US.
in one article I read, and this was from 2009, so I don't know what it would be now, but it was in children under 5, it was like 5 to 6 cases per 100,000,
Wow.
and then in adults it was more like 1 to 2 per 100,000.
So it's very rare,
Yeah, it's for sure.
very unusual to have this.
Mhm.
But we're given the drug here, so,
And
never know
why
when it's
does,
gonna pop up.
Yeah.
why does this medication cause people to have an increased risk for meningitis?
That's a good question. I think, like Renee said, I think that the patient population in general is just, susceptible to that kind of infection. I couldn't, because I figured that question would come up. I couldn't figure out like what specifically about the medication, increased your risk for that, or why this one in particular. So I can look more into that, but that's a good question.
Thank you.
Yeah, anytime
makes you susceptible to
I'm gonna say that
everything.
would increase your susceptibility to
I
everything.
mean, it's the
Right.
same with all the RA drugs and
Yes.
and the psoriasis drugs and that kind of thing. Any of those will lower your immune system to the point where you're susceptible to, I mean, I think the big one is tuberculosis. But,
Yeah,
Yeah.
Yep.
I think so too. That's a fun drug. I won't forget the Suns have on it.
Right, yeah, thank you.
Thank
Thank
you.
you.
And now I never